handcuffed, with information, whether it's good or bad information, how people can empower themselves.
Exactly. Okay.
Yeah.
Hello, welcome to Black Men Speak. I'm your co-host, J.R. Stewart.
And I am your co-host, Tommy Duncan. It is Wednesday night at 9 p.m., Jimmy, and we know what happened. Absolutely. Right. It is time for Black Men Speak. So welcome, everyone. It is Wednesday night. We are ready to go, and we are very, very pleased to have a very special guest who is going to kind of co-host and share some information today that, of course, the entire world has been dealing with over the last year and a half or so. My good friend and compadre, and also our fraternity brother, Charles Mcpherson. We're going to, before we get the show started on our subject, he's going to introduce himself very briefly, Jimmy, but let's do our preliminary announcements if you have any before we get the show started.
That's correct. I want to give a big shout out to Liquid for providing our theme music. And if you haven't already, please subscribe, like, and then spread the word. Help share information about our show. We're on every Wednesday at 9 p.m. Central Time. So with that out of the way, Tom, let's get to our introduction of our great guest.
Absolutely. So, folks, we're going to talk about a little bit more about COVID. So a couple of weeks ago, we had a resident physician and also an educator to talk to us a little bit about COVID and the impact on a lot of families getting their kids back into school. But we're going to dig a little bit deeper today and talk about how COVID has exposed Black American. And in particular, we're going to talk about how it has exposed what was already, what I believe to be a massive healthcare crisis that was going on. And COVID just created all types of havoc on it. And so our special guest today, he's kind of in this area, but he's been in medicine and pharmacology for a long time. So, Brother McPherson, if you could just briefly introduce yourself, tell us about your background, where you're from, what you're doing now, and we'll go from there.
All right. Thank you guys for asking me to be a part of this podcast tonight. My name is Dr. Charles Mcpherson. I'm a clinical assistant professor. I work inpatient in internal medicine at the University of Illinois Hospital in Chicago, Illinois. I've been on faculty at UIC at the College of Pharmacy for well over 24 years now, and I am also the assistant dean for pharmacy undergraduate education here at the College of Pharmacy in Chicago. To give you a little bit more about what I do, because there might be members of your audience, Tommy and Jimmy, who have never met a pharmacist that does what I do.
Exactly. So just so you know, he is not a pharmaceutical sales rep, okay? Right. Just so we make that clear. So let you explain what you do.
All right. So normally when people, when they talk about a pharmacist, or when they meet a pharmacist, everyone thinks of the pharmacist that works at CVS or at Walgreens.
Correct.
And absolutely, pharmacists do work in retail or what we call the community setting. As a matter of fact, pharmacists are the most trusted healthcare professionals, and they are most accessible. You may not be able to go see your doctor anytime that you want to have a question about something going on with you or medication. Typically, you have to call in. You talk to a nurse practitioner probably who will screen the call and then, try to get you set up for an appointment. But we have statistics that show us that most Americans live within a 5 mile radius of a pharmacy, and you can walk in at any point in time and ask whatever question you have, for them. The thing is that, we don't have an examination table and room in the pharmacy, so we're not able necessarily to perform a physical to see what's going on with you, but we can definitely answer certain questions related to healthcare, your access to healthcare, whether or not you need to be referred immediately to an emergency room to seek a higher level of care. And we can answer, again, a lot of those basic questions that most Americans have about their health. So again, we're the most trusted healthcare professional, and we are one of the most accessible, even though we're not the largest profession. Now, that's pharmacy in general. What I do is a little bit different. I am what's known as a clinical pharmacist. I work inpatient in a healthcare setting. And believe it or not, I'm not the only one who does this. There are thousands of pharmacists like me who do what I do. We started coming on the horizon in the late, I would say, 60s, early 70s. And so there's at least about 40 to 50 years of experience with clinical pharmacists, again, going on rounds with physicians, making recommendations about drug therapy, which is what I do, helping the members of my healthcare team come up with a treatment plan for my patients. So again, I'm not the one that's listening to breath sounds and reading the EKGs, but I sit around in a room with my physician colleagues. And once the diagnosis is told to me, then I am the drug therapy expert, and I help them come up with a treatment plan tailored to our patient population. So just as I'm in internal medicine, there are pharmacists who do what I do in many of the specialty areas, critical care. So for some of you who have seen someone or maybe have been to the intensive care unit, there are pharmacists making sure that the drip rate on those pumps that are hanging from the IV poles are going in correctly. There are pharmacists in infectious disease, in cardiology, in neurology, in pediatrics, so we have subspecialties just like they do in medicine. It's just not as many. Okay. So we're widely abundant, and we are a vital part of the healthcare team. And so I've been doing this for 24 years. And I just want to share with you guys maybe some personal anecdotes, but what my contribution has been in this COVID era. Because if you guys don't know about Chicago, we have a lot of Black and brown people who live here. This city is majority minority, so there are more Latinos and African Americans in this city than there are people of European descent or our Caucasian counterparts. Okay. And so because of that, we do see a lot of cases. My hospital in particular, Tommy, I know that you're located in Dallas, so it's not necessarily our county hospital, so it's not like a Parkland hospital, okay, but it is the state of Illinois' only state-owned hospital, and it's the safety net hospital for the state of Illinois residents. Okay. So we see a lot of patients who are uninsured and underinsured. Okay, so similar to a county hospital, again, if people don't have access to healthcare, they come to us. Okay. The reason why that's relevant is because I see tons of COVID cases. As a matter of fact, I see for many of our patients, they have many different ailments because they oftentimes don't have access through other routes or to other private healthcare systems. We see them in their worst state oftentimes. So I get the gravest of cases is the point I'm making.
Okay. Gotcha. That makes very good sense. So it's similar to what most folks might call a county hospital in their major metropolitan area, except it's owned by the state.
Right. Exactly.
Gotcha. No, that makes sense. So there are a lot of things to cover, and we have about an hour to kind of cover some things. But, when I think about this initially, and this is kind of kooky because I remember in probably the first quarter of last year, and this new COVID thing was coming out, and nobody really knew what it was. Nobody knew where it came from. They thought it was, some caged animals in China or someplace else pushed out some potentially lethal virus that's about to explode all over the world. And I remember some of the original narratives that somehow Black folks couldn't catch this virus. It was somehow we were immune to it. And I was like, okay, this is interesting. I don't know what it is, but it sounds kind of...
It was a low number of cases in Africa, I think is what
exactly.
People jumped to that conclusion. But we know here in America, that wasn't the rule.
Absolutely. Right. Absolutely. So talk to us a little bit about some things that you saw in the early stages of this virus, and we want to kind of move forward into how Black Americans fell into such a deep hole in terms of the number of cases, in terms of the number of fatalities. I think that obviously mainstream America, white America, numerically have lost more people to this COVID virus. But when you look at the percentage, I think the percentage of total population, I think Black folks probably have the highest percentage, with the exception, interestingly enough, of indigenous Americans.
Right. Exactly. So going to the first part of your question, like what are some of the first things that we saw? And, it wasn't that long ago. It was probably, closer to about, I'd say like 18 months ago,
Right.
Maybe 19 months ago when we saw the first cases. And again, because I work inpatient in a hospital, I round on these patients every day. I can tell you guys, for everyone who works in healthcare, this was a scary time for us because we did not understand the virus. If you guys remember some of the early information that was being disseminated at the time,
It was all over.
we didn't even think that the virus could be spread through aerosols. So by you talking to someone or singing or being in a club. So there are some infectious diseases that are very, very easily spread through aerosols or through the air. Influenza is one, but the COVID is much more transmissible and easily spread, even compared to influenza. So again, we had not seen anything like this. Another thing, if you guys, and again, if you turn on the TV and you saw the public health reports, we didn't even have tests. So we had people that were sick, but we didn't have the test to make the proper diagnosis because the initial test came from the CDC and they sent them out to public health departments. So like state public health departments, like the Texas Department of Public Health, who then had to disseminate them. And typically they disseminated them to academic medical centers. So we're rounding on these patients every day. We don't have adequate quantities of PPE, protective equipment. We're being exposed. So you have tons of healthcare professionals actually being taken out by the virus, believe it or not. So, and every time we had an exposure, you had to go home and quarantine for at least 10 days. So that meant that I couldn't be at the hospital helping out my colleagues. It wasn't just me, but my physician colleagues as well. And, you have to realize that hospitals, we don't have benches that are that deep where you can just take 10 people out of circulation, 10 healthcare professionals, and easily replace them with someone else. I didn't have any physician colleagues that I lost, but you guys, if you know a nurse or a nurse assistant or an LVN or an RN, take your hat off and salute them, because those people were in the trenches the entire time. And some of my nursing friends, some of them lost their life at my hospital because they're with those patients day in and day out. So again, we didn't understand the virus. We didn't have the test to detect the virus. So we were being exposed. People, healthcare professionals were contracting the virus. And then we didn't have face shields. We didn't have the proper mask, N95. We were being told, once we learned that it was spread by aerosols, to reuse those masks, because there just weren't enough in circulation to properly provide all healthcare professionals throughout the country with proper PPE. And we also have to wear gowns, and we have to wear booties on our feet when we go into these patients' rooms. So again, we just didn't have enough. And, it was just a lot of sad stories that we witnessed. I mean, and there's one I'm going to tell you real quickly, but we can get on to the other topics. And sure. I'll never forget, I was on the nursing unit, and I work, again, in internal medicine. So I'm on a general medicine floor. I am not in the intensive care unit or the ED or anything like that. But so many of these patients, we have better strategies for treating and managing these patients today, but we didn't at that time. We didn't know what to do typically that was life-saving, that could help prolong life. We didn't have very much in our armamentarium to help treat these patients. So once their oxygenation dropped, and some of you guys might be familiar with something known as like a pulse oximeter. You can buy them at a regular pharmacy now. It's a little thing that we put on your finger to see how well you're oxygenating your blood supply.
Gotcha.
All right. So we have more advanced equipment in the hospital. And so when these patients, when their O2 saturation levels dropped, typically into the 80s or so, what would be called at that point is a code. So the lights would go on outside the patient's room. Over the microphone, you'd hear number 1 emergency in this patient's room. So to be on a nursing unit, with 100 healthcare professionals, to know that a patient is crashing in his or her room, everyone running to the room, but nobody running in because we don't have masks, we don't have gowns to put on, and having to wait until a team comes up from the intensive care unit, and they wear these things that look like spacesuits. If you guys have looked at like Ghostbusters or something, I mean, they're helmets and everything. And so we know we're very well trained. I'm BLS trained, and many of my colleagues not only are BLS, but ACLS.
What does that mean, BLS?
So basic life support, and ACLS is advanced cardiac life support training. So we have the proper training. We know how to go in those rooms and save those patients, but we would do that at the risk of our own lives.
So let me ask you this. I mean, we've had lethal viruses out there before, obviously. We
had SARS-1.
Yeah, we had SARS-1. Obviously, influenza has been around for a very long time. I mean, if you think back a little bit over a decade ago, I mean, there was the Ebola scare, for a period of time. And it's interesting because I can't remember the name of these movies, but I have seen movies that have almost foretold of something like this happening, where there was a virus that could literally either kill people or turn them into zombies or something like that.
Yes.
But I mean, my question is this. It seems like the writing has been on the wall, and I'm just curious, how can we be just totally caught off guard this bad, and for it to go for this long a period of time, where I'm not going to say we've seen a virus like this before, but it seems like it's been coming, and people have been talking about there is some great virus that's going to be coming, and we just were caught completely flat-footed. Do you think it's the politics of the situation? Was it red tape within the medical? What's going on? I mean, it's just strange to a lot of people.
Say, Doc, before you answer, can I jump in on that question also real quick?
Yes.
I honestly believe that the rumors about this Wuhan virology lab doing testing on SARS-1 and spiking it to make it more infectious, because SARS-1 may have killed about 900 people worldwide. It was lethal, but it wasn't very contagious. But why would anyone in their right mind, left mind, any mind, go take that thing and spike it up to make it more contagious as a potential? I mean, this thing wasn't jumping to humans at the time. I mean, there was, whatever bats had it at that time. I mean, they were in the caves and doing bad things. But why would anyone in their right mind take that we knew of worldwide with SARS-1 and make it SARS-2, basically COVID-19, and then run the risk of letting it leak out somewhere? I mean, that is crazy and insane to even play with stuff like that.
Right. I definitely agree with you. I'm not a virologist, and I don't work in a laboratory, but, there are Department of Defense programs that we have, that other countries have. There are also research programs. Some of them are federal. Some of them are affiliated with academic medical centers. And, some of these are used as bioweapons. So they're looking at weaponizing, just like, for example, anthrax is one that some countries are, not the Western countries. Like, I don't think that the United States would ever weaponize anthrax, but it can be, and so we have to understand that it can be, so that we have in our stockpiles the drugs like doxycycline that we use to treat. So we have that in our national stockpile, we have drugs for that. So again, they have to try to study the natural course of some of these infectious diseases. Some people do it for scrupulous means, or some governments do it for scrupulous means. Others do it to try to better understand. That's the best way I can put it to you. One thing that's really weird about this one, and Jimmy, you mentioned, or you hinted on this, is that I think that what surprised everyone was the fact that you have to realize that man lives in proximity to animals, especially domesticated animals,
Right.
all the time, right? So this is nothing new for us. So different animals, depending on the species, depending on the type of animal and the species of the animal, they may have certain infections that are innate or specific to them.
Correct.
No one would ever suspect that this coronavirus, because bats, we know that bats have them.
Right.
That's a natural host, and it doesn't make them sick
Right.
the way
It
it
doesn't
makes
make them
us sick.
sick. They have too much body heat.
Right. So it's a natural. They live symbiotically with one another, but no one expected it to jump from an animal to a human the way that it did. And now we do have examples of that in history where not only viruses but bacteria can do that, but it's not easily done. It takes decades of frequent exposures for something like that to occur. Dr. Fauci says that he believes that there was some type of intermediate host. So in other words, a bat didn't bite a person, or a person didn't wander into a cave and get exposed to the virus that way from bat droppings. He believes that there was some type of intermediate host, like a pig or something like that, and someone ate the infected meat, because everyone, when we first heard about it, was like, what, are they eating bats in Wuhan? Now, I've been to China. I've actually lectured at 6 cities in China, and they do have these wet markets, and there may not be bats in those wet markets, but they do have a lot of animals that they do. And the same is actually true in Africa. I mean, people in certain parts of Africa, they still eat bush meat. And that's how Ebola learned how to jump from animals to humans and survive in humans. Okay. So again, it can happen. It's not a common phenomenon, but when it does, it can have deadly consequences, as we see. Another thing that you guys mentioned, and you guys are actually doing my job for me. When you look at the impact of a virus like SARS-CoV-2 on the world, the way that this one has impacted the world, two things are going to be very, very important to you. One is transmissibility. So how easy is it to infect one person to another, right? Mm-hmm. And lethality. If you catch it, how likely is it to kill you? With SARS, both of those numbers are high with SARS-CoV-2. So that's even different, for example, like flu, okay? Flu might be infectious, influenza, but it's not killing us at the rate that COVID or SARS-CoV-2 is killing us, right? And then when we start getting into the variants, oh my gosh, now we don't have tons of data. There are some reports that say that the Delta variant is more lethal than the original or the Wuhan strain.
Yes.
But what that may be the case, but what we do know beyond a shadow of a doubt is that it's definitely much more transmissible.
Yes.
Compared to the original form of the virus. As a matter of fact, it's so contagious that it completely replaced all the other alphabet variants that were here before it. So now all of the new cases, 99%, you guys, of the new cases of COVID are due to this Delta variant. It just completely pushed all the other ones out.
So let me ask you this, so that people understand, so that I understand this. Hypothetically speaking, you have someone who may have contracted the COVID virus, the original COVID-19. And then let's say they get exposed with or without the vaccination by the Delta variant. What are you saying when you say it completely wipes everything out?
Right. So what I'm saying is that in a population of people, in a geographical location, because the Delta variant is so contagious, so infectious, that it is infecting people at a rate that's much faster than the original version. So what we were dealing with in February and March of 2020,
yes,
we were dealing with the amateurs. So if you think in terms of like the Olympics, we just had the Olympics last month. That was the prelims. You're dealing with the pros now. Delta is a professional, right? Yeah. So it has completely eliminated. It didn't kill the other strains, but it has, because it's much more infectious, contagious, transmissible. Its impact on the population has grown exponentially in a short period of time. And just so you know, there's proof of that. So do you guys remember when the vaccines rolled out? And again, we're talking about, I was fully vaccinated January 11th because I have direct patient care. I'm in the healthcare environment. So as soon as those vaccines came out, I was one of the first people, right? Most people were getting access to the vaccines, I would say, unless you were elderly or something, most people was like March, April, something like that.
Right.
Once we started getting doses in arms, we start seeing a lot of our rates as far as the number of cases, hospitalizations, and death. They just plummeted. It just went down. So much so that the scientists at that point were theorizing that it's actually preventing infections, not just severe illness and death, but the vaccines were preventing infections. The Delta variant came around in May. And again, it went from being like 5% of the cases to within a couple of months becoming 60, 70, 80% of all new cases. You guys, we began to see our vaccine efficacy decrease. That's right.
And so, Doc, you are correct because I was vaccinated back then. When I started hearing the numbers were going down, I thought it was safe to get out, start traveling again, and start living life. I mean, I'm vaccinated. I thought I was safe until I caught, I believe, what called the variant, the Delta variant, and and actually, I'm still kind of recovering from it after 3 weeks. I mean, it had me down for 2.5 weeks where I didn't have enough energy to hardly get out of bed. So that thing is really bad. The good thing is I have a ventilator and machines here at the house for breathing. I think that helped, and I hope just getting a lot healthier than I was. Because I think if this had happened last year, I'd be dead. I mean, I was so unhealthy with high blood pressure and congestive heart failure and diabetes that I'd be dead if I had caught that thing a year ago. So focusing on improving health, losing weight, getting my blood pressure numbers down to normal range, getting rid of the diabetes where I'm no longer on metformin or Trulicity or any of those diabetic pills or medicines, I think helped me when I caught it over the summer. I mean, just here a few weeks ago, which probably helped me deal with it. Else, you guys probably be attending my funeral via, Facebook or something, because I don't know if the wife would invite anybody out these days. But I think you are absolutely correct. I mean, I heard the numbers were going down. I thought it was safe to go back outside and start living life again. And as soon as I did, I got infected and got sick.
So let me ask you this, and this is kind of a carry on to what he said. So we know what some of the symptoms and responses were of the original COVID-19. Of course, this do you have chills, headache, flu-like symptoms? A lot of people that I talked to, they lost their sense of smell, their sense of taste.
Yeah.
Help us understand, because Jimmy's just talked about a situation where you may have caught the original virus, and then there comes the Delta. Is there a significant difference in terms of the symptoms? We know it's more aggressive. We know it's easier to catch it, but is there a difference? If you didn't know, how would you know if there is, if that's a fair question, of what the symptoms were with the original version versus this Delta version in terms of symptoms, in terms of bodily response, et cetera?
That's a good question. I can tell you that it's not a black or white answer, in response to that. So it's not something, for example, where I can say if you experience these particular symptoms, this is definitely the Delta variant.
Gotcha.
Right. It's not that simple because we call them constitutional symptoms, which basically means you can have a myriad of things happening to you. Some people, believe it or not, even with the Delta variant, especially in the era of the vaccines, some people are asymptomatic. They don't even know they have it at all. They think that they just have some congestion.
And
right?
this is the Delta variant.
Right. That's
okay.
And that's with the Delta variant. So the most common things are, again, still cough and cold-like symptoms. So fever, chills, congestion, runny nose. A lot of people experience headache. I will tell you, not everyone, which we saw this with the Wuhan version, a lot of loss of taste and smell. a lot of our patients don't necessarily complain of that now. I mean, so I don't know if, and again, you have to realize this is anecdotal. So, and what I mean by that is, I don't know that we're still learning about this virus. So we may find that different variants do result in and cause different symptoms. But right now, we're not able to tease that information out. What is unique and what is weird about this virus, you guys, is that every organ system in your body can be impacted. We have not seen that, not with a respiratory virus. Do you understand what I'm saying? You would think that this virus would just cause flu symptoms.
Right.
You can get myocarditis. You can get like inflammation of your heart. There's something called a COVID fog where people have neurologic sequelae. So they're not even able to think straight.
Wow.
They're not mentating properly. It can cause, and because of those things, so that's in addition to the respiratory or the lung symptoms. So in addition to that, you know, all of that stress will cause problems, for example, for your kidneys. So we have patients who come in and they have acute kidney injury, and all of this results from the initial or primary COVID infection. So again, we see many more organ systems impacted with SARS-CoV-2 or COVID-19 compared to influenza and other type of respiratory viruses like RSV, respiratory syncytial virus, which is very common in kids, and sometimes the elderly get it, but it doesn't make us sick. It doesn't kill us the way that this one does. We've just never seen anything like this.
So,
Gotcha.
Doc, we have a question on the chat line. What does Dr. Mcpherson think about lifestyle medicine and preparing the body in this event?
And what is lifestyle medicine?
I would imagine that maybe more natural treatments.
Right. So I'll get into that. Okay. So, Jimmy, you actually hinted on this earlier when you said that, you know, getting those risk factors under control.
Right.
So weight loss, getting diabetes, your hypertension under control, all of those things are going to be paramount. You know, your cholesterol. And now if you have underlying lung disease, that might be different, because if you have COPD from chronic smoking, I don't know how you can't reverse that process.
Right.
You know, there might be things that you can do to delay further decline in lung function, but you can't reverse the process. Now, healthy lifestyle is always going to be important, but there are reports of things that might be beneficial. And you guys notice that I said might be, because again, we're still trying to study these things to see if they have a true benefit. Some of those things include things like vitamin D.
Right.
Okay. So vitamin D, actually vitamin C is another.
Okay.
Acai berry is something that again has been studied. So zinc is another thing. Now you have to realize that in these studies, the formulations of those things that I just mentioned might be slightly different than the Good Nature brand that you find on the GNC on the shelf. So the point I'm making is that it might be the number of international units might be substantially higher, you know, and it might be a different formulation of those vitamins. So I'm not recommending that people just go out and buy tons of that, because we're still trying to discover what their role is in either prevention or treatment of COVID-19. So again, those are some things that have been studied. Some of the smaller studies that don't necessarily have the power. The power means that there weren't tons of people. I mean, they looked at, you know, some of these studies are looking like at 50 people. You need thousands of people.
Yes, you do.
So that you can find out if this is truly a benefit of the drug itself, and that it's not due to chance. Okay, so you need thousands of people. You need a prospective study. That's one where you take one group, the control group, and you take the treatment group, and you follow them over time. That's how the vaccines were studied. So in other words, you need a prospective, a randomized, placebo-controlled prospective study to properly evaluate this. And so I'm just letting you guys know those things that I just mentioned, the vitamin D, vitamin C, zinc, acai berry, they may be beneficial, but today, right now, we don't know if they will prevent you from getting it.
Okay.
Let me ask you this, as we kind of carry forward this, and we're kind of backing up to an earlier question. How did our community, when I say our community, Black and brown communities, get in such deep trouble with COVID so early in the process? Why were there so many more infections in our community? Why were there so many other deaths after it penetrated our communities? Based upon the data that you are aware of, at least.
Right. So a lot of it has to do with something. I don't know if you
and this is even pre-vaccination.
Right. So a lot of it has to do, Tommy, with something known as social determinants of health, right?
Okay.
So these are the conditions where you work, where you live, where you play, go to church or whatever, and all these things impact your health risk and your outcomes, right? So what are factors other than the health conditions that we just talked about that can impact your response or your risk of contracting the virus? Poverty is one. Housing, not just Black people, but Black and brown people tend to live in more closely crowded conditions. Okay. Access to healthcare is one. Mm-hmm. Also, you guys, we talk about frontline workers. I'm a frontline worker. We also talked about early in the pandemic. Remember this? Essential workers. So many of us are essential workers. So we couldn't avoid the virus if we wanted to. So we're the ones, and essential workers are, the jobs where people who are working like in the grocery stores, who are in public transportation, driving the buses in Chicago, driving the trains. They weren't allowed to stay home. So this was at times where we didn't have adequate treatments for COVID. So they were constantly put in situations where they were in risk of contracting it.
Right.
Okay.
So Doc, I have a question for you on the underlying condition. So before the show, we were talking about it a little bit, and so one of the studies I saw kind of broke it down, and I think they went and studied a bunch of cases of people who was dying, and basically they outlined like 5 or 6 things. I remember obesity was number 1, stress was number 2, and I think it was heart conditions, diabetes with complications, respiratory issues, and then diabetes without complications. And then they had some more things that went on down the list, but those are the ones that I kind of remember at the top. They said if you had one of these things, it increased your risk of dying if you caught COVID. If you had 2 or more, the percentages shot up to the point that if you came into the hospital and you were sick and you had 2 or more of these things, it almost made it seem like you were pretty much guaranteed to die at that point. My question is, the study didn't say anything about whether these conditions were being treated by these dead people or not, but does it help? If you have these conditions and you're under medications and you have it under control, is that enough to help protect you, or are you still at risk simply because you have the underlying condition, whether you're treating it or not, of increasing your chance of dying or having COVID be fatal for you?
So having those conditions and them being uncontrolled puts you at a greater risk of having an adverse outcome. Okay. If you contract the virus compared to you having those conditions and being adequately medicated for them. Okay. So uncontrolled diabetes, that person is at higher risk of having an adverse outcome. By adverse outcome, I mean severe illness or death, right? Compared to somebody who has diabetes, who's had it for 10 years, but is very well controlled. He or she has reached their goal, hemoglobin A1C, which is the marker that we look at to determine long-term glycemic control. So again, if you look at those 2 groups, it doesn't mean that people who have controlled diabetes won't get the virus or won't die from it. But typically it's at lower rates compared to their uncontrolled counterparts. And you are absolutely correct. Having several of those risk factors increases that risk, again, of an adverse outcome even more.
Okay. I.e., get healthy.
Right.
Quick.
Yeah. Take your medications, man. Get healthy and take your medications.
But keep in mind, this is what I want your listeners to know also. Yes, there are health conditions that can increase your risk, not only of contracting the virus, but having an adverse outcome. But just keep in mind that, healthy people get the virus and they die from it too. So, if you guys think about the number, they're not dying from it because they have access to healthcare. Mm-hmm. But we had Olympians, there NBA players, football people are contracting the virus, You remember when the NBA players had to play in the bubble and they have these COVID protocols. So people are getting it, but again, it's their access to the best healthcare and physicians. They're getting treatment early, including these monoclonal antibody infusions, you guys, which are great because they keep you out of the hospital, out of the intensive care units. And if they're started early enough, they can prevent you from dying.
So, Doc, why isn't that message put out more by our government, by Dr. Fauci, everyone? It seemed like the message is just vaccine, 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 and very few people are talking about the treatment of some things that can help. Like you just said, that those antibody infusions, which is just one of the trunk treatment cocktail that he took. But we know there's stuff out there that powerful people and rich people and wealthy people are getting, and some of this stuff they even say is over the counter. So can you speak to that shortly before we go to the next question?
Sure. So let me tell you what has been studied as far as treatments and what we know that works. All right. One of the first things that we found, and it's a drug that's so old, it's generic. It's been around longer than I've been practicing, which has been since 97. And this is dexamethasone. So what we found is that patients who were hospitalized, so if they had a severe form of the disease, so let's say they were in the intensive care unit, they were on mechanical ventilation, okay? If we gave them dexamethasone, which is a steroid, you guys, so if you may not have heard of that one, you may have heard of prednisone, okay? So it's a cousin to prednisone. We found that patients who were given dexamethasone, 1 tablet a day at 6 milligrams, you give them that for 10 days or so, you're actually preventing death. Those people are coming off ventilators. And it was just amazing because this is not a new drug. This is a drug that's been around forever. But we found that what it did is it stopped your body from attacking itself. Okay. When you get SARS-CoV-2, it induces such a great inflammatory response. What happens is you have the cells in your lungs that become inflamed, and so they're releasing these inflammatory mediators. Then your lungs get filled up with fluid, you can't breathe, and that's what causes people to die, right? So it's acute respiratory distress syndrome, right? So we found that giving steroids to those patients, you're actually stopping the body from producing and releasing all of those inflammatory mediators that destroy lung tissue and lung cells. So that's something, again, old drug, been around forever, but we found out that it works and it saves lives. Another drug, remdesivir. Now that's a drug that we use. Again, we use it for patients with moderate illness. There are some things that we have to look at in our patients. So we have to make sure that their kidneys are working pretty well and that their liver is working, because we can't give it because it can cause adverse liver effects if someone has, for example, like cirrhosis or something like that. So I'm looking at all these things before we complete the protocol to see if we can place a patient on that particular drug. Other than that, it really, if you don't have kidney disease or liver disease, it's a great drug to put people on. Again, what we have shown with that medication is that for patients with moderate illness, that they can be or they might be in the hospital, but they can be discharged sooner, with and get over their viral symptoms sooner when they're being placed on that medication. So those two, and then there's another thing that we do for these patients. We have found that COVID-19 or SARS-CoV-2 increases your risk of developing blood clots.
Ouch.
And so for patients that have moderate illness, we are putting all these patients on blood thinner medication to make sure that they're not getting these blood clots. So those are the three things that are going to be the standard of care for people with at least moderate illness. In addition to being on things like high flow oxygens, if you're in an intensive care unit, you might be ventilated or intubated. Now the antibody cocktail that I told you about, the monoclonal antibody cocktail, that medication is for people who at the onset of symptoms. So someone, and hopefully your listeners, and this is for you guys too, if they start experiencing symptoms, they need to call their primary care doctor immediately. Now, most communities, we didn't have tons of these places a year ago, but I guarantee you where you guys live, they have these places. We have them. I know someone who lived in Katy, Texas. There was an old strip mall that they used just for this antibody cocktail. So you don't even have to go to the hospital. They
Okay.
just, they
And
just
where's
took
this called
empty
again?
space, put beds in there, put healthcare professionals, the freezers and things that we need to contain this medication. And this medication works so good. Again, for people with mild to moderate illness, it works so well. Again, it's a joke, but we've had stories of people being wheeled in a wheelchair, but they walk out.
Right.
And what is it? And what are these places called again? That are being set up?
They're called infusion centers.
Infusions. And how does one find out where they are in their community? They just Google it or what?
I'm going to Google it.
Right. So my hospital has one. So all academic health centers, they have an infusion center associated or affiliated with the university. But there are some that are located in the community. Now, you have to realize that the practice of medicine is based upon state law. So, for example, here in Illinois, we have infusion centers. Ours might be run by a nurse practitioner. In Texas, it might require a doctor's order. So I'm not necessarily certain. You guys may have to find that out.
Okay, I'll research that.
And why don't we do this for a quick second? And we do have some folks who are listening to the show. Folks, for those of you who are out there, we hope you're enjoying this conversation. We certainly hope you're learning something new. If you have any questions, please take the time to chat, ask a question. If you would like to call in, you can call us at 972-497-2280, 972-497-2280. If you have a question for Dr. Mcpherson, he's sharing a lot of information. I know that there's a lot to process here. We have a little bit more time, maybe a quarter inch of an hour or a quarter of an hour left. So we want to try to get as much as we possibly can. So one thing that you talked about a little bit earlier, and you're living in a large metropolitan area. We also live in a large metropolitan area, and the impact that it is having in our larger cities. You got Chicago. We live in DFW. There's New York. There's LA, and all of these other places where the majority of black and brown, the black and brown population are. What things do you see that we need to start looking forward at in terms of managing risk, managing health? Obviously, taking care of our health, obviously getting the bad numbers down and getting the good numbers up. But one thing I do know and that I have seen, when after the vaccinations started going out in mass, a lot of folks stopped wearing masks. They stopped doing some of the things that they were doing prior to that. What things do we need to continue to look at? Because we are still trying to figure out what this disease is, how to manage it, how to control it.
Right. So before any medication was developed or discovered to manage SARS-CoV-2 or COVID-19, the only things that we had in our armamentarium were things that we could use were to prevent the disease or prevent ourselves from contracting it. Right. And that's the 3 W's. All right. Wash your hands. All right. Walk 6 feet or distance yourself 6 feet from the next person, and then wear a mask. Those are things that we can do. Whether you don't have to take any medication. Well, I won't say that you don't have to take any, but I'll say that it can decrease your likelihood of needing medication if you exercise all those points.
So that's wash your hands, wear a mask, and what was the third one?
Distance.
Right, walk or distance yourself 6 feet from the next person.
Gotcha.
Right.
Gotcha.
So those are things that can help you. Now, again, after the initial rollout of the vaccines, because cases had dropped so much, the CDC, again, and I don't fault them because I understand that this science is evolving so rapidly. But initially they said, if you're around other unvaccinated people, you don't have to wear your mask, Well, they have changed that recommendation. They no longer are saying that at this point. So what you guys need is
if you're around other unvaccinated or around other vaccinated people.
They're saying around other vaccinated people
Okay, gotcha.
that you don't have to wear your mask.
Right.
That recommendation has changed. So now, and this is what we're doing in Illinois, if you are in a indoor setting, period, vaccinated or not, we recommend that you wear a mask.
Yeah, I'm back to wearing masks.
Why?
All the time.
Why? Because let me be very clear. Go to Home Depot, you go to restaurants. I don't go out and socialize at all, but places where there are a lot of people, let's say gas stations. So in Texas, I don't know if they have like these Buc-ee's. They're like these huge gas stations. They have a big store inside of them. You get all this other kind of food. I was driving, I think it was not too long ago, and I passed by Buc-ee's. We were going to get some gas, and I went inside to use the restroom. Maybe 60 to 70% of the people that I saw were not wearing a mask.
You're right.
Well,
You're right.
Wearing a mask, Tom, and
it was densely populated. Densely populated.
I think I saw someone testify before Congress that said even people who are vaccinated with the T cells and antibodies, you go swab their nose, you may find just as much Delta virus, I don't know, whatever you cells or whatever inside their passages as a sick person. So, it just seems like, just being vaccinated is like false armament. You can still get you can still catch it, you can still spread it, even though you've been vaccinated. You just have a lesser chance of maybe dying if you're vaccinated, but it offers some help, but it doesn't seem to be the cure. So like I did, I got foolish. I started just walking around thinking I was okay because I was vaccinated. The numbers were going down, everything was looking good. Next thing I know, bam, I go to a reunion, I come back and I'm sick.
Absolutely.
We have a couple of questions for you, Doc, and I do want to say, people, this guy is an expert in his field. I promise you that if you had to go out and try to hire him or someone at this level for private consultation, it's going to cost you a house note. So take advantage of this free moment. Free. So just pick the phone up and call. So we have a couple of questions.
Let's get the questions. Okay.
One, someone wants to know your opinion of the Biden mandate for companies with 100 employees or more. What do you think about that? And then I guess the exclusion for some unions.
Basically, what he was saying is basically trying to strong arm corporations to require all of their employees to get vaccinations or risk termination.
And then, is there any let me get you a couple of questions. You can ask them all at once. Is there any correlation between blood type and COVID? Some people say if you're O positive, then you may be a little safer. I'm O positive. I don't know if that was true. And
I'm O positive as well. I'm O positive as well.
I'm not sure what BL is in one of the questions. But let's just tackle those two: blood types and the president's mandate on corporations.
Okay, I'll do the blood type first.
Okay.
There was some initial thoughts or discussions because we were seeing that of the people who contracted COVID or had worse outcomes, many of them had the other blood types and not O, right?
Okay.
But as you are a living witness, you know that people with O blood type, they can, whether it's positive or negative, they can get the virus just like everyone else. So they are not naturally immune, from this virus. So again, there was some preliminary information. It may have to do more with the fact that O is not as common as some of the other blood types, that we just didn't see it as much, but I will tell you that I've had patients, my patients have all the blood types and they still, they come in and they contract COVID and they're being hospitalized. So don't hang your hat on a blood type, being protective. All right. That's the first thing. The second thing is this, gets a little bit into politics.
Yeah.
You guys have to have yes, the federal government and Tommy, you mentioned this, that is Biden trying to strong arm, the country? He is, and being in public health or being a healthcare professional, I agree with it. You know why? Because you guys, as long as people refuse to get vaccinated, then you're going to have low levels of transmission occurring within a population. As long as that's occurring, you're going to have risk of more mutations developing. That's why you guys may have already heard of the Mu mutation already, right?
No, I haven't heard.
You have not.
No.
So there's a brand new one.
I've heard all the way
from Delta to Mu.
Oh, we going through the whole alphabet, brothers.
we went from Delta to Mu.
There's a Lambda too, but Mu. Now here's what the concerns are about Mu.
Okay.
Now, first of all, it's less than 1% of the cases so far, so it's not much to worry about. Fauci said he's currently not worrying about it because it's not able to overpower Delta. We're not seeing, and it's not more transmissible.
Okay.
There is some preliminary data, you guys, that suggests that it might be evading the vaccines, though.
Oh,
that's a problem. So when people are not getting vaccinated, viruses are going to do what they're going to do, what they're designed to do, which is mutate. And every time they mutate, they can mutate into a variant that can make it much more lethal for our population. So with Delta, let me tell you what the mutation was. So the cells that it infects in our body, the Delta variant, it binds more tightly and it gets into the cell easier. Okay. So sometimes this is just chance, so viruses, again, by nature, they mutate. And so it mutated itself into a form that, again, binds more tightly to the receptor and gets into the cells faster. And that's why you guys may have heard that the viral load, or the amount of virus of people infected with Delta, is like 1,000 times higher than those who, for example, had the Wuhan or the original form of the virus.
Yes, did hear that.
So let me ask you this, and for those of us, in our even our folks who are listening who don't really understand the clinical terms, how do these viruses mutate in the first place? In layman's terms, how do these things? I mean, they're like, oh my God, we're up to mutate. How do these things mutate in the first place?
That's what they do, Tom.
Right. I understand that.
Just said.
I understand, but
so it's in their nature to, organisms mutate, generally speaking, in an effort to create a better version of itself.
Right.
Okay.
Otherwise,
with viruses, because they replicate because viruses replicate so rapidly, it's really like a crapshoot. It's like rolling dice. I mean, they don't have an internal knowledge, because it's a lower level organism, so they don't have an internal knowledge of what's going to be the best mutation for itself so that it can thrive and proliferate. But the mutations that were actually lethal, that didn't bind tightly to the receptor, well, they didn't get transmitted, into that person or to the next person. Excuse me. So again, it's they do it by nature, because they're trying to form a better version of themselves.
Right.
It's just, it's like a survival of the fittest.
So obviously, adapt or die.
Well, and plus, since there's some debate about whether viruses are actually living or not, most say that they're not. But the doctor is right. I mean, they're just trying to live and infect our cells to spread and replicate. And boy, if they don't mutate into something else, we'd easily wipe them out and kill them. That'd be it. That'd be the end of it. So the fact that they have the ability to mutate is a protection against us developing a drug to wipe them out.
Right. And just to put this in perspective, you guys, of the G7 nations, so, we're talking about the most industrialized, the Western nations in the world. The United States is ranked number 7 as far as vaccine uptake.
Okay.
In other words, now, they were developed here, not just here, because AstraZeneca is Oxford, and now there are many places that are developing. China, India, they're being developed in other places too. But, we have the Pfizer vaccine and we have Moderna, and we had access before most of the world, but we have fallen behind the other industrialized nations, the other 6 industrialized nations, even though we're the wealthiest, but we have fallen behind them as far as vaccine uptake and our vaccination rates. So we have to get that met. So I think if that's the answer to the question about public policy. So Biden is doing it. You got to have political leadership that can help put in policies that will decrease the spread of this virus. I understand what's going on in Texas, but in Illinois, again, we have a mandate here in Chicago. If you go to the Bulls Arena over here, United Center, you're going to have to wear a mask. So all of our events indoors, you have to wear a mask. At my university where I teach, all of our students to come on campus, they have to be vaccinated or come with a doctor's note saying why they can't be. So it's public policy, things like that can help decrease the rate of spread, as well as the transmission, mutations, all of that.
So if that is the case, and you would advocate for our president or the administration to require companies to require folks to get a vaccine, would it not make sense that should roll down to our governors, that should require people to wear masks?
Well, he's trying. So what Biden can do is he can do this for federal employees. And what he has already done, he announced this already this past week, not just people employed by the federal government, but if you contract with the federal, so if you're going to do business with the federal government, your workers are going to have to be vaccinated if you want that contract. Okay. So you already have governors that are state governors that are suing him for that policy. The CDC has said things like, okay, you can't go on a cruise ship unless you're fully vaccinated and you show proof of a negative test. And then you have DeSantis in Florida, where most of the cruise ships depart from, suing the CDC for trying to implement that policy. So you have these state governments that are going against federal guidelines for vaccination implementation policy. And what's weird about this to me is the fact that there are already state mandates for vaccines. You couldn't go to school without them. But why is this one such an issue? Why this one? We're already getting vaccinated against polio, against measles, against mumps, against tetanus, against diphtheria. You have to show or demonstrate proof of immunization to go to grade school, to go to college.
Well,
you
Doc,
have
you
to.
know, I think the difference is there's a reward with the other vaccine mandates, in that if you want to get rid of your bad child and push them off on someone else for 8 hours a day so you can get a break, you get the vaccine. So
Right.
for adults, I would say if the government was serious, which they are, start sending out checks. If you haven't been vaccinated, if you've been vaccinated, here's $5,000. If you haven't been vaccinated, we'll give you $3,000. Make it a financial incentive for people to go get vaccinated, and I promise you, you can get that rate up to maybe 90-95%. There'll still be a few holdouts who will say, I'm not going to get vaccinated, I don't care how much money is involved, but I think most people will take the check and get vaccinated.
Well, Kroger is doing that, so they're giving $100 to their employees to get
100?
vaccinated. And so is Southwest Airlines.
Okay.
Southwest Airlines is going to give 16 hours of pay to their employees to get vaccinated. So that's the staff. But to flight attendants and to pilots, they're going to get 13 hours of additional pay if they get fully vaccinated.
We do have another question here that I'm seeing here, Jimmy, and I believe it has to do with the risk of COVID getting in food, the risk of COVID in food.
Food and innate objects that you may touch and put your hand in your face. I mean, what's the life? What is the I guess the life or the infection time? You know, if someone coughs and they have droplets that just land all over the place. I mean, how long is that virus that lands contagious?
And if I recall, it
Or
might
if it
be
gets in the
might,
food, can you die? Can you intake infected food and become contagious or infected?
Okay. I'm trying to answer this real quickly for you guys. So statistically, yes.
Okay.
Is it very common? No. Okay, so here's some things that you need to know. The most common means or mode of transmission is aerosols, so it's droplets. When someone sneezes or coughs who has COVID, remember I told you the amount of viral particles is 1,000 times with this Delta variant, 1,000 times more compared to the Wuhan strain, right?
Right.
But it sits out in the air. So, Tommy, it creates this cloud that's just airborne, and you might be walking from an area into the cloud. So again, aerosolized droplets are the most common means or route of spread. Does it mean that you can't get it from surface contact? It does not mean that. Okay. Mm-hmm. Now, the type of surface is important. So the type of surface that the virus is on, it lives on certain
wood versus metal, that kind of thing.
Exactly. So the type of surface is important. So again, because of the potential for touch contamination, that's why I gave you the 3 W's. So we're going to recommend that you wash your hands. Soap and water is going to be best. If you don't have access to soap and water, use hand sanitizer. But hand sanitizer should not supersede soap. When I work in a hospital, you know, we have sinks and soap, you know, all over. There's stations where we can do that. So but if you don't have access to that because you're out in the community, use a sanitizer.
So what you're saying is soap and water is actually better than hand sanitizer?
Yes, it is. Yes, it is.
Now that's interesting because I wasn't. I mean, I knew both of them were effective, but I didn't know that soap and water was better than hand sanitizer.
It is, but you need to do it you need to properly wash your hands. So in other words, you need to get in between the crevices. Absolutely, and then you need to make sure that you do it. I mean, we recommend a minute, but you may not necessarily have to have an exact minute, but a minute, and make sure that you lather your hands so you can wash those particles down in the drain. But that's going to be your best defense. If you don't have that, again, sanitizer is going to be the next best, you know. But again, like you mentioned, whether it's steel or like if it's cardboard, so it depends on the surface as far as how long those particular viral particles are viable. and can actually cause infection, because many times they die rather quickly, like within minutes to hours. But on certain type of surfaces, they can live longer.
And you mentioned something that was kind of intriguing to me. So you talked about somebody breathing and creating a mist, so to speak, where the virus could contaminate the air. And you also mentioned someone coughing and I guess really extrapolating the virus. So to break it down and keep it very simple, I could be in certain area and somebody's, let's say, active with COVID virus. I could be walking in an area that they were and get the virus.
You absolutely can. You absolutely can. You absolutely can. Let me make this more plain for you. I'm from Oak Cliff, and there is a 7-Eleven on the corner of Hampton and Ledbetter.
Yes, sir.
And this is when there were no vaccines available, and we didn't know what treatments were going to be the best for this. And I was in line getting ready to purchase an item, and the two people in front of me had bought something from, they have these like the hot dogs that turn on the rollers or whatever.
Right.
And they pulled their mask down, they're eating, and they're talking, and there's a line of people behind them. So me knowing what I know about this virus, who wants, when they move out of line, to walk into that fume of viral particle? Right. Everyone should be wearing their masks. Everyone should be wearing their masks, because if they don't, now what I don't know is if they had the virus, and I don't know that. But again, the fact that people are not wearing them, yes, you can be exposed. So that's why places like nightclubs where you're trying to yell over the music, football stadiums, you guys, where people are yelling all the time. So you're actually projecting virus out into the air.
Well, that counts as my plan to watch football games live this year.
Same here. So I'll be watching on the big screen. I'm okay with that. Let me see. You get the last couple of questions, Tom?
You know what? Let me see if there are any more questions. We have
about,
a lot of
hand washing. It still offers the same protection as the flu, protection against the flu. And hands and eyes, nose, mucous membrane. So I think you covered some of that.
Right, and I think, the key things that we're hearing,
keep your hands out of your face.
Is that, vaccinated or not, you got to continue to wear your mask. You need to continue to wash your hands.
Right.
You need to continue to safe distance. Do not get comfortable just because you got the vaccine. And the reality of it is you can still catch the vaccine.
That's true.
You can still suffer the consequences, and you can potentially die. Now, let me ask you this. With the Delta variants, is it more aggressive than what we saw with the Wuhan version, the Alpha version, with the younger population and the healthier population? Because we knew, or our take is that the original version really affected a lot of our senior citizens and a lot of people with underlying symptoms. Is it pretty much the same with the Delta variant, or are you seeing younger people? We know that there's no vaccine yet for, I think, children under the age of 12. Is there a greater risk with the Delta variant or other variants for younger, healthier populations?
Actually, you touched on what the answers to that question are. So one is, you have to keep in mind that the way that we rolled this vaccine out, it was the most vulnerable within society, right? So like the elderly, our seniors or whatever. So those individuals were vaccinated. And like you just mentioned, if you're under 12, you can't get vaccinated, not currently.
Right.
Believe it or not, we're going to see that by the end of probably this year. We're going to see between 5 and 12. You'll see that our 5 to 12-year-olds are going to start getting vaccinated. Okay. Right. So you guys so you heard it here first. So you should probably start seeing that happen like around November or so. The information has already been submitted by Pfizer.
What do parents need to be concerned about when they think about the development of their younger children's immune systems being at that age? And what is it that's going to be different potentially about a vaccine, considering that they're not eligible yet? What makes this other vaccine so different that it's safer for their young children who are still developing, obviously, their immunity and other body systems?
All right, so I'll answer this real quickly for you guys. Because
there are going to be a lot of parents who are going to probably be very concerned for their young children.
Absolutely. And I would too, because children are not just little people, So in other words, the doses that we're using for adults, we don't know that children need doses that are that high. So that's why it's important that we allow these companies to study the proper doses of these vaccines for our younger people, right? Because 5 to 12 is what's going to be the next group rolled out, then 2 to 5, and then they're going to look at 6 months to 2 years old.
Oh,
but
wow.
all this data, the data has to be collected, submitted to the FDA, evaluated by the FDA, evaluated by the CDC before the recommendation is made as far as what age groups can get this particular vaccine. So again, you want them to study the lower doses. Now, why might that be important to a parent? What we have seen with these vaccines, and specifically with younger people, is that there is an incidence, we call it myocarditis. So there's inflammation of the muscle of the heart, okay? So we have seen that more commonly in young people than we have in our adults and seniors, okay? So again, we want them to get the dose right because we want to see less of that particular adverse effect or that side effect.
So, Doc, does that mean the heart is getting larger? Is the muscle growing? Because I know there's limited space in the body cavity there, so there's not a lot of room for growth here. I mean, technically, what does that mean exactly?
So basically, myocarditis means that the heart is a muscle itself,
right,
but it becomes inflamed, and so it can increase your risk of getting fluid in the pericardial sac. So these patients can develop tamponade and die. They can, if it causes permanent damage, these patients can have heart failure. So you can have, 10-year-olds, 15-year-old kids who've had such severe damage that they have permanent heart failure. Okay.
Yeah,
so that's why it's very, very important that we allow the pharmaceutical companies the time that they need to dose these vaccines in our children. Okay.
Is that a few months, Doc, or are we talking a few years? It seems like that should be on the few years path rather than a few months path.
Well, believe it or not, they got started in the spring. So they've already collected the data. Most of these companies, even Moderna, I think Moderna started in May collecting this data. And again, they're rolling it out in batches. They're not saying 6 months to 12. They're doing 5 to 12 first, and then 2 to 5, and then 6 months to 2 years old. And again, they are studying more than one dose. So they might study 100 micrograms, 50, 25 to see if the antibody response is going to be the same, because what you want to do is you want to have the same effect. So you want to have the same amount of antibody production with the least amount of drug exposure.
Right.
So we have to test different doses.
Got it. Okay.
Well, I'll tell you what, I know we are right about out of time, Jimmy. It's a couple of minutes after 10 o'clock. Man, this has been an absolutely enthralling and informative conversation. So before we close out, we'll maybe have you to share any closing remarks with our audience before we close out this evening's show, man. We're going to have you back sometime in the future, man, to talk about this and other areas, man, that you feel strongly about. So what are your closing remarks? And then we'll close out the show.
Okay. What I would suggest to your audience is that if you have not obtained the vaccines, please get them.
Okay. Good advice.
If not for yourself, get them for your loved ones. Because again, your children don't have, especially if they're under 12, they don't have access to the vaccine yet. So if you want to protect your children, your immunocompromised loved one or family member, or your older adult parent or family member, please get the vaccines. Black people are dying at rates more than twice our white counterparts.
Yes.
And when you look at vaccine uptake, we're like at 17% or so. And guess what? Half of those individuals live in the black belt, is what we call it, or below the Mason-Dixon line. So half of the black population in the country lives south of the Mason-Dixon line. And that's where we're seeing the greatest problem. That's where we're seeing our people most disproportionately impacted. Wow. So our Floridas, our Alabama, Mississippi, Louisiana, Texas, Georgia, that's where we're seeing the greatest impact as it relates to black people. So you are within the sound of my voice and you live in those places. Again, not for yourself, but for the people that you love. Please get the vaccine. If you have questions, talk to an entrusted healthcare professional. Facebook may not, and social media may not be the best place to get vaccine or scientific information. So please talk to an entrusted healthcare professional to get the facts about these vaccines.
Okay, good advice.
Absolutely. Hey, we appreciate your time. We appreciate
Thank
your
you so
input,
much,
man.
Doc.
This has been a wealth of information. Jimmy, you have any closing thoughts before we shut everything down?
I'm just going to tell Dr. Mcpherson that he has carte blanche to come back anytime he wants to. I mean, you call us, say, hey, I want to come back and be a guest on the show, and you got it. We even have to bump somebody. So, the information you provided has been so valuable. I wish some people would have called in and asked you questions directly, although they did send questions via the chat line. But like I said, guys, if you had to go pay the private hourly rate to talk to someone at this level, it would cost you a house note. So you had a chance, but we're going to do our best to bring the doc back in the future anytime he wants to come back. But I want to know more about this Mu variant now. I need to look that up and find out what my danger exposure is. So, but thank you so much.
All right, no problem.
And for those of you who are familiar with Black Men Speak, we always close out with a prayer, and that's our resident chaplain here, Tommy Duncan.
All right, folks, we'll gracefully bow our heads, dear Lord and gracious Father. We come before you this evening and thanking you for bringing us back together again, Father. We thank you for the information that has been shared today. We ask that it may be a benefit to someone, Father. It may save someone's life. It may make a difference in someone's life. We ask you would keep us focused on the special gifts that you have built within all of us and help us to stay in our lanes, Father, and do your will on earth as it is in heaven, Father, that we may continue to do that which is to love and take care of our brothers and our sisters, Father. And for all of these things, we thank you and we praise you. And in your precious name we pray. Amen.
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 All right.
So we are wrapping up now.
All right.
How long you gonna have to stay at the office tonight, man?
Oh no, I'm headed home.
All right, good deal.
I'm headed home.
Good deal, man. How was the concert the other day?
Oh, it was good. It was Chicago is still having outdoor. Actually, they have an outdoor and indoor. But you know what they're doing though? Again, see, these are things that you guys can do in Texas. They're easy things. They're checking proof of vaccination status for you to even get into the venues.
How are they doing that?
So you can have a digital copy. So like I have mine on my phone. I just took a picture of my card. Some people have their original card, and there are apps where you can upload your. So